This is ASAP Pathway. Hi, everybody. Welcome to another episode of the ASAP Pathway podcast. We're doing something today a little different. We're going to have a joint podcast. We've had Mike DeLuke on before, Dr. Mike DeLuke, and he runs the Doc podcast. So we're going to have our joint podcast today and have some really exciting discussions. And welcome, Mike.
Well, thanks so much, Stacy. And I'm so excited to be having this joint podcast with the ASAP Pathway group. So Stacy, Tracy, Michelle, thank you so much for being willing to do this. I know it's not easy to coordinate all of our different schedules, and I really appreciate you all taking the time. I'm definitely looking forward to this interaction and some of what we're going to talk about today.
Thanks for having us too. This is great. And there's been a lot of behind the scenes up front trying to figure out how we're going to edit this thing. So this is great.
That's right. Like, how do we do two separate? Yeah. So for our audiences, I guess, bear with us a little bit as we work through some of the flow of this to be able to let it be produced in both platforms.
But something we were saying before, Mike, before we started recording was, we both kind of started this thing, 2 years ago about the same time. And I think you had a great idea of all of us on today, and everyone's got different perspectives, different speaking venues and groups that we're kind of a part of, to just really talk about where we've been, where we are, where we're going. And I think that's a really good, a good discussion to have.
Yeah, I love the way you frame that, is where we've been, where we are, where we're going. And it's important to me to recognize all of those things, right? We have to know where we came from in this, because we have made a lot of progress. Sometimes it doesn't always feel like it, but other times it really does. And I think it's important we all maybe talk about some of the progress that we've made, where we are as far as what are we facing now? What are the challenges, and what things do we need to do to help get this message out to more providers and more parents? I'm sure you do as well. I have a lot of laypersons and parents that follow my show, follow my content, and constantly getting emails and questions from them on this. So they're aware of this now. And I really feel we need to have a vision for where we're going. What do we want to achieve? What does it look like, say, 5 years from now, 10 years from now, as far as what the average dental professional, orthodontist, pediatric dentist, general dentist does when it comes to airway with their patients?
I think that's a really good way to say it. What does that even look like? Because we can sit there and, what's the ideal scenario look like for us when we're sitting around these tables having discussions? What does the environment feel like? What does collaboration feel like? I know, Tracy, you were talking about that earlier, just, and maybe that is something we do, where we used to be years ago when we started with ASAP, which is crazy. Almost this December will be 6 years ago we did our first speaking event, and
we're still here. We're not going anywhere.
We're not going anywhere.
Good.
And the ADA had just started coming out talking about pediatric airway. I want to say that was in
2017.
2017. Yep. So we've come a long way. And the American Dental Association is very open and passionate about having this discussion and making pediatric airway screening part of the primary care dentists, everyday screening, oral cancer screening, you've got airway screenings. So I think we should say, wow, look how far we have come.
Speaking of the ADA, I was just at the ADA Children's Airway event, and they do that every year. And funnily enough, actually, ASAP celebrated our 5th year anniversary, right? So this is our 5th year. We put it together 6 years ago, but we launched 5 years ago. And this year, I took my son with me. And so before I was a dentist, before I was an airway dentist, I'm a mom. And the reason why I'm here is because of my son. And that son, Matthew, was about 3 years old back then when I first started looking at all of this. And now he's 18. And coming full circle, I brought him to the ADA Children's Airway event. And Mike, when you said we've come a long way, from a dentist perspective, I can appreciate that we've come a long way, but from a parent perspective, we have come such a long way. There's so much more resources for parents these days, podcasts like what you have, like what we have in ASAP. There's so much more information, books out there that was not present 15 years ago. So we have come such a long way.
Yeah. What are your thoughts on that, Tracy, too, from what you've seen? You're out there lecturing, you're speaking. We all are speaking nationally on this. You, I think, have even a much busier schedule than the rest of us. So talk to that a little bit. You were recently out in Seattle, right, at the Koi Center with talking. So what is obviously sometimes you're speaking in front of a more airway aware group, right? And then sometimes not. I didn't even talk to you about this, Tracy. You were up, didn't you give a talk up in Albany at Saratoga?
Mm-hmm.
That's my old stomping grounds. That's where I used to practice. And they were not, I mean, when I was up there, I have to say, still in the orthodontic community, I don't feel that they've progressed much, sadly. I still hear from a lot of patients, past patients and parents, and they say they just wish they had somebody who thought about airway the way I did and looked at it the way I did. So I don't know about the non-ortho community per se. But so again, you're speaking in front of groups that are just maybe a group of colleagues that have limited or no knowledge or interest in this, to groups like at the Koi Center where you're going to have sort of the most knowledgeable, so to speak, in a concentrated audience. So what is that like? And what are you hearing as far as what did you used to hear 5-10 years ago versus where it's not, where does that now?
So actually all of these organizations really were not airway aware. And I think what's happening is all the major teaching institutions are becoming more airway aware. So I would probably say like the first teaching institution that became airway aware was Spear. And then slowly now Dalston's pecked in. Penke, I don't know if they have a curriculum yet. Coyce has a curriculum. Seattle Study Club has a curriculum. So they're talking about it at every symposium. I think what you're starting to see right now is the restorative doctors are driving the movement. You know, and it's coming to the point like, so when you have, I mean, trust me, even at Coyce, people are not like, okay, like how does this at the Coyce Center? It's a heavy restorative based education center, just like Spear Center. So they're like, okay, well, I would probably say 80 to 85% of the dentists in that room do not treat children. So like they're like, okay, why are we talking about this every year? You know, and I think what's happening is, but we all have children. We all have people that are affected by this disease at every age from birth to 90, you know, so now it's starting to be a discussion of like, how does how does this disease affect our management from the dental side? I mean, if we think, and I think we have to think about that like that. If we think about heart disease, you know, the periodontal world has changed drastically due to inflammation, the oral systemic inflammation. Now that hasn't changed the periodontal community, but it has changed the oral systemic connection. And that's kind of what you're seeing now with restorative dentistry. We're definitely talking about it more. So hence why there's getting a lot of pressure in the orthodontic community, because restorative doctors are asking, like, how does this affect the dentistry? You know, and so restorative, the orthodontists who are part of an interdisciplinary team, we want to know how you can be a part of that team. And I think that's the real thing here is like, you know, airway dentistry is not the solution. It's part of the solution. And I think that we have to talk about it like that and find ways for us to kind of come together to manage our patients better.
Yeah, that's really well said. And it's interesting because I have found, and I've said this on my show with different guests, that a lot of the orthodontists who are more airway aware, it's come from one of two areas or both that you each have hit on in what you were saying, Michelle, and what you just said, Tracy. And that is, it's either very personal to them, meaning it was a family member, and or that orthodontist did some time in general restorative dentistry. And so it lines up exactly with what you're saying, that they can personalize this in some, because we are limited by our experiences, right? And if we've gone through all this school and education as an orthodontist, being one myself, I can speak to it, right? Got ABO certified, went through all these different hurdles and steps to get to where we get, and literally heard nothing about airway the whole time. It's really hard to wrap your mind around the fact when you get out there that when that restorative dentist calls you or that parent comes in and says they're worried about the way their kid is breathing, you're like, I'm the expert on this. I've gone through all this school on this. And I don't mean that arrogantly. I'm just saying we're victims of our own experiences.
Right.
And it's like, this isn't a thing. This isn't a thing. And so I've had so many people that I teach and coach who started thinking that way that have changed. And they're like, maybe this is a thing. And it's become from pressures from parents, as well as maybe a personal experience with a child. And as I said, experience in restorative dentistry. And I spent 3 years doing part-time restorative work, moonlighting during my ortho residency. And I saw the 40-year-old females with teeny, narrow, constricted arches and no tongue space, falling asleep as soon as I would put them back to do a crown prep or to do some restorative treatment on them. And I had no idea at the time. I'm going back to my ortho residency and I'm pulling teeth and constricting these arches and not doing anything to help grow the face, not even close to making the connection between the two because I wasn't being taught it. But as I started to get exposure to it down later in my career, it started to make more sense. Wait a minute. And she was, on psychiatric meds and just gone through a divorce and having severe emotional trauma. I didn't put any of that together. None. Like that it could maybe be the way she's breathing. I had no idea. So yeah, those are great points. Stacy, what are your thoughts on that?
I just feel like, again, this is where we do need to give props, like what you're saying. I'm the expert. I don't mean to say that in a way. You are the expert. You did go to school extra. You guys know growth and development really well. Like this is where sometimes you see on the other side among some of the primary care dentists doing interventions, they're like, they might get a little frustrated why they're going up against an orthodontist and they feel like, why won't you do this? Why won't you do this? And you're right. This was not discussed at all in the schooling. So you have to give grace to the specialists that are coming out. And this was not discussed at all. Hey, dentist, this wasn't discussed at all in our schooling either. So what we're all having to realize is this is something we've discovered and come across, noticing it in our practices, extra education outside of our, training. So we have to give grace to each other that maybe someone just isn't in the place where you're at. And how do you have a discussion with that person respectfully as colleagues to get them maybe more open to where you're coming from? But, I think too, like Courtney Levine, she has made discussions on this too, sometimes the practitioner, the dental, the dentist, the dental practitioner is coming to them going, hey, I want you to expand. And with the knowledge the orthodontist has on growth and development, they're like, where do you want me to put these teeth? How are you wanting me to do this? Like, and the orthodontist in my town that I've been having discussions with, they have said, it's not that we don't want to help you. It's not that we don't think that this is helpful to the patient. Some of the orthodontists don't necessarily have the mechanics that they think would work in their toolbox to give you what you're asking.
Or the behavioral patient management knowledge. Remember, we don't see young kids in our residencies. Not going to paint everybody with that broad brush, but I could barely say maybe 90% of the ortho residencies out there probably see in their time there fewer than 5 kids under the age of 8 or 9 ever. Think about that. So we're now expecting them to go out and just know how to manage a 3-year-old. And the workflow of our practices isn't conducive to this either. I ran a very busy, very successful orthodontic practice, and it was extremely challenging when I started treating younger kids and changing my mechanics and doing things younger, to your point, to incorporate that it's a cog in the wheel. I mean, like, you're set up to be very efficient, hyper efficient at moving teeth. That's what an orthodontic practice is set up to, for the most part. Again, there's outliers, obviously, but for the most part, right? When you then try to think of the extra time, and I want to talk to you all about this part too, the extra time you're spending diagnosing. So recently, lectures I've been doing when it's not a bigger group where it's a in the hundreds where you've got kind of a little smaller group and it's quaint. I'll do some of those as well, study groups, and I'll ask them. And sometimes I've even done it in bigger groups for a show of hands and had people guess. Let me actually ask you three. Start with Stacy, then go Tracy, Michelle. What would you say is the average amount of time an orthodontist spends in the diagnostic process? Not some of the outliers who are doing a lot of airway based, just the average orthodontist who's just focusing on straightening teeth. Stacy first.
Okay. So when you say how much time are they spending in diagnostics, are you saying time with the patient or even behind the scenes looking at the case? All of it.
I guess you could separate it if you wanted to be fair. Like
So
let's just start with how much are they in the
chair
room?
time.
Patient chair time. And that patient walks in the chair. Let's just say it's a 7-year-old, right?
It's a 7-year-old. They're sitting in the chair, butt in chair. Orthodontist walks in the room and is taking a look. How much time is that being spent? Patient, doctor time.
Yep. Interacting with the patient and the parents.
And then I'll say, and then later they look at the case to come up with the treatment plan, how much time that is.
Maybe that might be 0, obviously, if they recommend observation or
well, I've gotten a lot of
So-
letters. I've gotten probably 5 letters this week on placing lower lingual holding arch and upper nance and evaluate in 6 months to maintain leeway space. Like I've gotten 5 letters this week.
Yeah, it's insanity. I mean, again, you want to talk evidence basis, we can get into a conversation about that too, but that's not evidence based either. But
no, agreed.
Yeah.
You know what? I was told that those were okay. This is sorry. I don't mean to be mean to any of my ortho colleagues. I love you guys so much. I do love you, my ortho colleagues. But I had he is a mentor of mine, and he's been doing orthopedic intervention, orthodontics and orthopedic intervention for like 40 something years, seeing all these crazy, awesome health changes in kids. He happens to be a primary care dentist that decided to do this, but he said, do you know what a lower lingual holding arch is? Do you know what an upper, TPA is to hold those leeway? It's just a thumbprint for an orthodontist to put something on that kid and say, this kid's mine when they're ready for ortho. That's all they're doing. Like,
and constrict the transverse growth even more. So you have more work to do later.
He wasn't even talking about how it's actually stopping growth. He was just like, it's just what they do to put their mark on a patient. So they don't, later they're like, no one will touch them till I get the phase 2 ortho ready. Anyway, it was so funny. But anyway.
And more than that, feel like they're doing something for the patient, for the parent, because the parents come in, they're like, they know they're super crowded, or they know they have these problems. So it makes them feel like, well, I'm not just doing nothing about this.
There's something in their mouth.
Yeah, there's something in their mouth. So amount of time, average orthodontist walks in, 7-year-old. How much time are they in that room with the parent and the kid?
They're in the room, I would say at the most 10 minutes.
Oh, that's generous.
And then on the average case, they probably don't spend any time behind the scenes sitting at their desk reviewing records. It's pano. There's probably rarely a Ceph. Panoramic, 10 minutes chair time at the most, maybe. And then they're probably already telling the assistant when they walk away, it's going to be watch, observe for 6 months, or if they're ready, okay, we're going to go ahead and move forward with phase 2 treatment, and it's going to be anywhere from 18 to 24 months of time with retainer at the end.
Okay, and so then you're thinking about 10 in the room. 10
in the room, and most of the time there's nothing behind the scenes. I don't think they're looking at records really later, unless it's like a severe class 2 or class 3 case. Then they're going to sit down
outlier,
and go,
obviously.
Outlier.
Right. Your average garden variety, we can even make it, for argument's sake, 7 to 14-year-old. Let's just keep it that
class
range.
Class 1 malocclusions that they see. Yeah.
Okay. All right, Tracy.
I think it's fast because I would say like 5 minutes. Like I think they already know what they're doing once they see the records. Because a seasoned orthodontist already knows. Like, all right, this is what I'm doing. But,
Yep. Okay. 5. Michelle.
And I'm a fan of business process and workflows. And so I study a lot of orthodontists, and you guys are like my hero when it comes to efficiency and just workflow and everybody knowing what to do when. It's like a beautiful dance. And so I would say, 5 minutes. And with a great treatment coordinator, it's going to be, 5. I would say 5.
Okay.
On average.
When I've asked audiences this, typically the orthodontists in my audience say 1 to 2 minutes.
Wait,
Well,
wait. Is that 1 to 2 minutes that they already know what they're doing, or is that 1 to 2 minutes of time that they actually spend in the room talking to the parent?
The latter. So what typically happens in ortho practice, which is how I ran mine as well, you do what's called a one step. Again, I'm painting this picture not in any way to be critical of orthodontic colleagues. I mean, I did this too, and I'll explain how I was able to, why it was a challenge for me, because I hope this gives some context to why we have the challenges we have as we're talking about how we go forward in the future to get our orthodontic colleagues on board. It's really important that non-orthos understand what's really happening behind the scenes in an ortho practice. Tracy's exactly right. Once you do this for a while, there's only so many malocclusions you see. There's only so many ways to fix it, right? So in the beginning of my practice, I had all these different categories, and I tend to overanalyze and be a little too detail oriented on things sometimes. And then as I started getting more confident and more proficient, I'm like, this isn't a good system. This isn't a good workflow. So I streamlined it. And you don't have many paths that you're going to take these patients. And then you add in that you start getting comfortable with your approach and your appliances you use, and you kind of fall down these paths. So what happens in most practices is they look, the records are taken, unfortunately, not often enough a CBCT. And so they're looking at a pan, like you said, Stacy, maybe not even a Ceph, even though we're told you got to treat to these Ceph numbers. Yes, I've gotten many second opinions from orthodontists over my career, and a lot of times there is no Ceph. And so they're looking at a pan, and they look in the mouth, and they might look at the pictures in the pan before they walk in the room, and a Ceph is one is there. And then they know within 30 seconds, they have their preconceived thought of exactly what they're going to do, because they compartmentalize it, right? For efficiency's sake. And then they walk in, they greet the kid. They might do a quick clinical exam. There's very little review of systems or medical history unless something is an outlier. Child's diabetic, needs antibiotic prophylaxis for some sort of dental procedure, right? Some sort of congenital heart anomaly or malformation. So unless there's something that's a significant outlier, you really don't review much about their medical history, because you think these are kids, they're healthy, right? If there's nothing, you don't look into, you're not asking about how they sleep, how they breathe, how they do in school. You're not asking about behavioral issues, neurocognitive. You're not asking these things. We're not trained to ask this stuff. We don't ask about, have they seen the ENT? Have they seen the allergist? We may ask if their adenoids or tonsils have been removed, but we don't ask if they've seen these providers. We don't ask if they have allergies. We don't ask these things. So we look quickly, we see let's just go with the 7-year-old with 6 millimeters of crowding in each arch, deepish bite, right? Maybe they lost the upper C's a little early because the laterals caused them to exfoliate prematurely. So we look and we say, well, yeah, let's just try to hold that E space, which again, show me the data that's not, show me the true research that says that preserving E space is the best way, because you're not treating the problem. You're just robbing the space from the posterior. You know, the patient isn't crowded because they have too much E space, right? That's not why the patient is crowded. So I never understood this whole preserve the E space. And then people will talk about needing to practice from a quote unquote evidence-based perspective. You're not treating the problem when you're preserving E space. You're just trying to prevent the natural mesial migration of the 6-year-old molars into the E space, which is then going to increase the impaction rate of your second molars and cause other problems, which then forces them down an extraction pattern, because the only way to get out of that at that point down the road 3-4 years later is to pull permanent teeth. So they look at that, and in their minds in that moment, they know what they're going to do with that child. They then walk in, they meet the child, they look quickly. Yep, Johnny's got a deepish bite, this and that. He's not going to have enough room for his teeth. They're not looking at it from even though we are the experts in craniofacial growth and development, we almost forget all of those studies and articles that we read and what can be done early to grow these patients. Because at the end of the day, most of us don't want a 6 or 7-year-old in treatment in our practice. We don't know, our team doesn't know how to manage it. We don't know how to schedule them. We want braces on, adjustment visits. That's how our practices run efficiently. So we look quickly, we make a determination. Let's say it's a 12-year-old retrognathic, right? Great. Basically going to be a herp, need a herps, need a MARA, whatever you're going to use to fix the class 2. Unfortunately, headgear or upper buys would be some of the things people would propose. And you're just making that determination right away. So I think it's important for everybody listening to understand, and I say this to grant those orthodontic colleagues some grace, that when you're telling them you need to do this more thorough diagnostic and comprehensive evaluation process, not only did they not learn it, they don't know how to do it. And they certainly don't know how to integrate it into a busy orthodontic practice where they're seeing 75, 100, 125 patients a day?
I think it's okay for orthodontists to not treat children under 6. If you're not comfortable with that, I had this discussion with one orthodontist in my area. It's like, if you're not comfortable with seeing them because of behavioral issues, lean on your pediatric dentist. And I think what we're seeing now is more and more pediatricians are managing these kids. I mean, the reality with these kids is like, for us to be a part of a team, you don't need to understand everything. As a restorative doctor, I can do that for you. I can tell you what I see. I need you to help me develop the face. And then I think we have to have that kind of discussion. It's kind of like, if we look at the evidence in the medical literature, by the time you hit 7, you're already too late neurocognitively. And then we have to just be like, okay, how can we be part of the solution, not the solution? And then we also have to understand, and I give my orthodontist grace, because I think as dentists, we are so hard on ourselves. We are like, we cannot have secondary decay. We cannot have open margins. We cannot go to anything twice. We cannot have a relapse, So when you do something, and I get it, like they don't want to do something because they might have to go back in again. If you're treating children, you're probably going to treat them at 6. You're probably going to treat them at 12. You might treat them again at 17, and you might treat them again at 15. And at some point, anatomy is not going to be an issue anymore. And then we all have to kind of understand that. But like when the anatomy is the issue, we have to, as a team, talk about it together. And I think that's where the disconnect is because everyone's focusing on anatomy at every level. And at some point, it's not. We just have to have like a conversation with, okay, what can we do to this child at this point? And I had a discussion with an orthodontist in my area. Like, I'm fine. If you're uncomfortable treating like the crying 7-year-old, I mean, like I get more and more autistic kids in my office that I've never treated before, that I'm starting to kind of learn how to manage. And it's okay to say that you're not comfortable with it, but it's not okay to say they don't have a problem.
Yeah, thank you. I'm glad you said that, because I was going to ask you that. So how do you reconcile that? Because I think that's a great point. Those are two separate things. One is I'm just not skilled enough, or I don't have the experience to do that. The other is this isn't a thing.
Exactly. And then I think that's where we have to kind of come to ground, like, and like when we were in St. Louis, like my whole lecture was, if I'm touching a 4-year-old, I am not advocating the prevention of orthodontics. And we have to be really honest with ourselves about that. Because I think that's where we are like beating each other up, because we are discrediting our own team. And we shouldn't be doing that. It's like, if I'm treating a 4-year-old, I'm treating a 4-year-old to maintain airway patency. I'm treating a 4-year-old because like the 4-year-old or the 6-year-old has already had tonsils and adenoids taken out, and everybody else basically waved a white flag. And at that point, who's next? I mean, that's the question we have to ask with these kids. Who's next?
What do orthodontists say when you say that to them? Because I agree with you. And what do they say when you present it that way?
Well, like, so if I'm working on a case with an orthodontist, like I will actually present like, okay, this is where I think that we might want to entertain. And then you start with your diagnosis. You don't just tell an orthodontist, I need you to expand, because arguably like where are you going to go? Like, is it really a transverse issue? Is it an AP issue? Like what are you trying to treat? And I think we have to, as a team, be like, what are our metrics? What do I need to be successful for us to be like, let go? I mean, and I think that's a conversation that we have to have with parents too. I mean, like I had a parent come in the other day and I was like, okay, what are our goals? I mean, the kid arguably was a surgical case, like skeletally. And she goes, well, I just want a bigger airway because I heard that's what I need. The child needs a bigger airway. And I can understand if that patient came to an orthodontist and a restorative dentist said, the child needs a bigger airway. Like the orthodontist would be like, I don't know what you're talking about.
I just had a coaching session literally 2 hours ago with an orthodontist who told me that exact thing was told to his patient by like literally like word for word.
Told that. And I said, it's like, well, what does that mean? Do you think a bigger airway is going to resolve all these symptoms that you just talked to us about? And I have to say, like, not to like boost because the beauty of the three of us is we actually know sleep. And so we actually are diplomats of the AADSM. So it's like, we understand the importance of the anatomy. Then we also understand that it's not the solution. It's part of the solution. So I think it's okay if it doesn't fit your practice. But again, don't say that it doesn't exist, because we are seeing I just want orthodontists to do really good orthodontics. I mean, like when we take a look
What does that
at,
look like? If you don't mind me asking, like
so like
when you
for
say good
example, like
orthodontics?
if I see like a 12 or 13-year-old or 15-year-old with a constricted arch and a great, sure, you can probably do that with brackets and wires. But if you have someone with a deviated septum, can we entertain? Can we entertain getting to point A to point B with expansion, not just brackets and wires?
Mhm.
And someone would say, Tracy, why do I have to do that? Because adding a TAD expander changes my workflow. Well, adding a TAD expander based on the evidence, we can actually probably influence nasal resistance, because there's not one article that I've read, and I could be wrong, that says straightening teeth out with brackets and wires improves airway resistance. Like there's tons of data on expansion and airway resistance. So like I do think how we get there matters. Like I don't think everyone with a 42 millimeter is great. No,
Mhm.
I think
Right.
so I think that we have to have that discussion on how we get there. So like, and I think, when we talk about extractions, I don't bash my orthodontist for wanting to extract teeth, because I've seen some of the crazy cases that come into them, and where you have the periodontally compromised arch, and they're like, well, we don't have any bone.
Mhm.
Well, how many orthodontists have referred to periodontists?
Exactly.
You know,
Right.
so like I
Right.
speak, well, we're talking about
Right.
women
They can
who are,
create bone now. Right. As
yeah,
you guys had George on recently. I've had George
Yes.
Mandelaris on. I
yes.
mean, we talked about SFOT. I mean, there's a lot that can be done. That's a great
Yeah.
point. Right.
So I
Yeah.
speak to a lot of periodontal groups and orthodontic, which is interesting because more orthodontist group are asking me to speak. But when I speak to an orthodontist group, a periodontist group, it's like, my question to you is, how many of you guys get referrals from ortho? Very little. They can count it on their hands.
Mm.
And I think orthos try to do too much. It's funny because I had this discussion with Ilya from a restorative standpoint. I was like, like for me, I don't want you to close the spaces. I can restore these spaces. And so Ilya, he was just like, well, I can't find restorative doctors to close the spaces cosmetically. I was like, okay, I understand that question. I understand, like, I think it's important to talk about your pains, together. Like, I want the spaces. And then with like, why but I think what I find is when I talk to my orthodontist about why I want to do from a restorative standpoint, they give me the spaces.
Mhm.
So I think there has to be a discussion. I think there's a lot of companies out there, and this is why we started, the three of us, that are alienating people in the community. And I get the backlash. I mean, when we have companies that are saying this appliance will cure your apnea, your
Mhm.
child is going to be a different child with this appliance. I mean, I don't even promise that in my practice,
Mhm.
and it hurts the community, so
Yeah.
I understand the backlash, but we have to find a way to come together, and be a part of the solution.
Yeah.
Yeah.
One thing I want to add too is just to clarify for my audience, because I do a lot of young expansion with brackets and wires. I agree with you. In the older patients, you're not going to get the orthopedic change, but there's lots of literature going back to the 70s on using light forces is actually
Yeah.
preferable in those younger kids. I know you weren't saying that, but just to clarify, because sometimes in the comments people will say,
Oh,
they're
yeah.
confused by
Thanks
that. So,
for the
but yeah,
clarity.
you're right. But
Yeah.
then in those ones that mean true skeletal changes when they're more mature, as Melson calls it, that adolescent suture, that older suture. So actually, I'd love to hear, Michelle, your thoughts, if you don't mind, on that side of it too. Like the whole, what your experience has been working with orthodontists and some of the feedback you've received and the challenges you face.
Well, I was just at the ADA, and we had the president of the AAO there. And like what Stacy said, every time the ADA Children's Airway event, every time we've attended it, we've had the president of the AAO attend.
Mm.
So I think that there's with all the contention and all the things that we don't agree with, I think there's a lot already that I think we're all seeing, and we can all agree. We might have to change, or we might have to understand everybody's verbiage and where everyone is coming from. But I think the way what we're seeing and what we're trying to accomplish at the very basic level, I think everybody can agree to so much already. So my cousin is an orthodontist, and she explained something to me where very early on, I'm like, I don't understand why orthodontists are saying that when we extract the teeth, we're not constricting the arch. We're not changing anything. She's like, yes, because there's a study that, when you extract a teeth and you compare the volume of the oral volume before and after, there's really not much change. And here I am with my general dentist hat, and I'm like, yeah, but I'm not thinking about it from an extract and keep everything the same. I'm thinking about it from a let's expand. And so I wasn't really in my head comparing extraction pre and post. I was thinking in my head 2 different treatments. And so it took an orthodontist, it took my cousin to explain that to me and say, we're saying the same thing. We're just not communicating with the same verbiage probably, or the same wording, but we are probably saying more of the same thing than not. And so when I was talking to Dr. Siegel, the president of AAO, right, he was saying there is I guess all the orthodontists now are getting screening tools, which I think was really good, screening tools for Airway. So I think it's a really good start, because awareness and screening and all of that stuff is where everybody starts. So if we can just figure out what we agree with and start with that first, and then say, okay, these are the things that are contentious, or these are the things that we don't agree with. But what are you seeing, and what do we as orthodontists need to see for us to say, okay, I see your point, right? So,
yeah, because the calling for the randomized control trials, and that was actually my talk at Panny, where when you referenced St. Louis, Tracy, and we were shared the stage there, and then I spoke as well as did Michelle at Panny, which is a great meeting. Both are great meetings that I highly recommend to everyone out there. But I was talking about the evidence basis and the challenges in that, and the one study I think that you referenced is the Larson study in 2015 that a lot of people will go to as a reason why there isn't a relationship between premolar extraction and airway compromise. That is a very, very flawed study in Journal of Clinical Sleep Medicine in 2015 by Larson and colleagues. And number one, they put the conclusion in the title, and that should be the first sign. As anyone who reads a lot of literature, has been involved in research, knows that's not what you do. But they actually, very interestingly, just take a moment to explain it, and I won't go into too much detail, but they actually didn't look at. So a lot of the orthodontists say, well, they won't believe anything without PSG. And I've already in my show and many times, and I know you guys agree, PSG in kids, there's a lot of limitations and restrictions and issues, and we don't have to get into all of that. So this was in adults. So we'll just say that, okay, they're going to have polysomnography done. That wasn't a part of the study. They determined the diagnosis of OSA on the ICD code from a chart review.
Huh?
Oh yeah, this is the vaulted. This is the Larson study that everybody loves. What's that?
Yeah, they're evaluating medical records.
Yeah, they look at medical records. Do you know what type of orthodontic mechanics were done on these 5,000 plus patients that they looked at? Neither do they, because they didn't even have to have orthodontic treatment to be part of the study.
Yeah.
So
do you know why they pulled premolars? Oh, wait, neither do they, because it wasn't for necessarily crowding. It could have just had a missing premolar because they had a vertical fracture, and that tooth was extracted in 2 of their arches, and maybe in another arch they had them extracted for crowding. It wasn't defined as part of the study. So they make conclusions based on orthodontic treatment, extracting premolars and airway, with literally no orthodontic treatment. Did they measure Ceph numbers? Nope. Didn't look at radiographs. Did they have CBCTs? Nope. Didn't look at radiographs. Did they look at lip posture position? Nope. Didn't look at photographs. They literally did a chart review of patients who had premolars missing in all 4 quadrants and patients who had ICD coded OSA. And they literally said that because out of those patients, and even so, the odds of having OSA they found when having premolars missing was 14% higher. But it wasn't quite at the level of statistical significance because it was a very large sample size. So, even just that random, useless sort of data, it still showed a 14% increase in the patients who were missing premolars having OSA ICD coded OSA from a chart review than those who didn't. I mean, the study is so poorly done. Yet I know, because someone messaged me who was at that meeting as well that you were talking about, Michelle, that and this isn't a slight to the AO president, I don't know him, but he said at that meeting, he quoted the Larson study as a way to refute what one of the speakers was saying. So to your point, Tracy, we need to do better on that. We need to have a common discussion. We can't just quote useless data and then call for randomized controlled trials, which, as we know, have all sorts of ethical challenges. And even if you look at when Sackett designed evidence-based medicine and when that all started, I mean, it doesn't say evidence-based medicine. It's really important for everybody to understand this, because your audience, a lot of them probably come up against orthodontic colleagues who say, I only practice evidence-based. Have you guys heard that?
Oh, yeah.
Oh,
Yeah. I would just encourage to ask them what evidence-based actually is, because evidence-based isn't randomized controlled trials. Evidence-based isn't just a systematic review. Those might be the highest form of research of which evidence basis is formulated. But evidence basis is actually a composite of three things, right? It's the research. It's essentially the data, so to speak. It's clinical experience and expertise, and it's patient values and perceptions. Three things. So if you think of it like a Venn diagram, evidence basis is where those three things come together. It's the confluence of those three areas: clinical judgment and expertise, relevant scientific evidence, and patient/parent values and preferences. And that Sackett says, when you have those three factors, it was a 1996 article in British Medical Journal, that is how you create a better decision-making process for patient care. It specifically says it is not restricted to randomized controlled trials and meta-analyses. And it says, if no randomized controlled trial has been carried out for a patient's predicament, we must follow the trail to the next best external evidence and work from there. That's really important for everybody to understand.
Absolutely.
Right? And that's the founder of evidence-based medicine, Sackett. So it's really important when we talk to orthodontic colleagues that when they say some of these things, and I don't believe it's coming from a bad place, and I mean that. I'm not just paying lip service. I really don't believe it's coming from a bad place. I believe it comes from a place of protecting their profession, their livelihood, their mental state. Like, who wants to think that they've been doing something wrong and could be doing it better, right? And then the stress of change and learning a new thing and implementing a new thing. I mean, if you're making patients look really good and you're giving them straight teeth and they look good and are happy at the end, what's your motivation to uproot your entire practice over that? So I think a lot of it just comes from being defensive, and that's how we all are, right? I mean, if someone threatens any of us on the way we do something, we're like, I didn't do that, or I don't need to do that, especially when it's yielding a pretty good outcome. So sorry for the rant on that, but I thought it was important to get that out to your audience.
No, I think it's a very, we do throw that word, we hear that word thrown out a lot, and we do say it ASAP, we talk about that. Let's just really remember what evidence-based medicine really is. It's not just literature.
Mm-hmm.
It's not just the research. That's not what it is. So it's part of it. It's a piece of this puzzle. It's not, you can't say, I'm not going to do it because there's no evidence whatsoever.
Or no randomized controlled trial.
No literature
no
on
RCT,
it.
So I won't do it. No, that's not
there's
what
no
evidence-based medicine
evidence
is.
that
Right.
works. But, and that's where these discussions are happening. And Mike, you've said something before in the past that I thought was really good. It used to be that literature included not just university-based studies, but it was also it was in dental offices too, or in medical practices. I mean, you had access to patient records, and it wasn't just to basically contain to university only, and probably things with HIPAA changed that. And
Yep. With hugely, and IB and IRB.
And IRB.
IRB was a big change that hurt that. Because you're right, Stacy, if you look back at the literature, look back at some of the studies that were done in like the orthodontic journals I can speak to most astutely, 80s, 70s, 80s, even early 90s. They were collaborations between private practitioners and academic institutions. You really don't see that much anymore, not to the same extent. And so I feel we need to get back to that. I mean, I'm not seeing a lot of good research. I mean, the AGODO, there are rarely any articles coming out of U.S. Orthodontic residencies, period, in that journal, like ever. So what are our ortho residencies doing? I mean, they used to pump out so many great articles into these journals years and years ago, decades ago, and they don't anymore. It's mainly are coming from overseas. Why? And like, why are our residencies not doing? Is it because our research isn't relevant? Maybe. Is it because they're not maybe putting forth anything that's quality research? I don't know. I mean, there's really smart people and really smart research at these institutions. I don't know. I'm just throwing it out there. But look, it's a big problem. Yeah, we need to collaborate. So how would you all collaborate? You guys have tons of data, each of you. How would you all be able, or would you all be able to collaborate with institutions near to you to help them run research projects and not just the best studies? And then
we went into like, how could we possibly collaborate even and get our information from our offices, as part of, and we do get people that, I mean, this is talked about a lot, isn't it, Tracy and Michelle? Like, people will say, how do we get all of you guys doing all of this in your practices? And how do we come up with some kind of metrics where we could, get data that could then,
We've talked about forming a PBRN, a practice-based research network. I know that there's a lot of members who are interested in participating and contributing to the literature in that manner. One of the reasons why many people have joined ASAP Pathway to be able to get the education, but many people have stayed because they feel like it's part of a community that helps develop this field and provides dentists resources that enable them to help their patients. And if you're talking about evidence-based practice, we know that one pillar of evidence-based practice is having the literature. And it's one of the things that a lot of people, all of us, it's like, which way is better? Is it slow expansion? Is it rapid expansion? So we have many questions, and we are all very cognizant that there's still so much work to do. So a lot of our members are actually very happy to participate in research with regards to collection of data and things like that. So we do have a research group. So if you're an ASAP member, you want to be part of any research that's coming up. Right now, all that's come up are questionnaires, but we have talked to 2 PBRNs, and we're always, if there's anyone who's doing research and they need clinicians in private practice to gather data or to do something, we're always available. So let us know.
Have you talked to UMDNJ at all?
No, not UMDNJ. It's right now it's Chicago and Texas, South Texas, I think. The PBR in South Texas is what we've worked with. I have not talked to UMDNJ, but maybe I should.
Are they Rutgers now? Are they?
Yeah, it's Rutgers University now. Yeah.
Okay. Dating myself with the
I just went right into UMDNJ too, and I was like, yeah.
Okay. Yeah. Well, and I know you've got to hop off, Michelle. But yeah, if so, can they reach when we finish? We'll put on my side, at least. I know your audience knows how to contact you. I'll put your contact info if there is anybody who's looking for a way to do some of that research, or at least to give their clinical information. They can reach out to
Michelle at asappathway.com.
Okay, great. I think that's big. I do. I think we need to start to find solutions to get our data out there, because it doesn't have to be a randomized controlled trial. As long as we can show good data. I mean, some of this be retrospective, okay, right? But we need to, some can be prospective, right? But we need to just put it together into a well-presented, well-thought-out thesis that we can show that it's having these effects. And then that becomes, per Sackett, the best available evidence, right, at that point. And then if someone can do a randomized clinical trial to disprove that, well, go for it, right? But until that's there, then we need things for members to point to, so that when people say there's no evidence for this. I've done so many literature reviews and searches, and I can quote the literature on all of these things. It's just, then there's like, well, that wasn't a good study, or that's too long ago, or, so again, it's at some point, we're never going to please everyone on the research side, but I think we need to find a way to get more of this amazing data just think of the data that between the four of us we have.
Right.
And
Well,
we
so
could,
that's the
right?
thing, right? With what you were saying before, there was much more communication between people in private practice and people in research, and we don't have that right now. And I think what we need as clinicians is some guidance from the research body. You know, so people who are in research, if they can give us these are the things to collect, or these are the ways to collect in which you get less bias. You know, so some kind of guideline that clinicians can take, and then it would be a more meaningful study, regardless of whether we know it's not a random RCT, but I still think that if somebody with a research background looks at how we're putting together a study, that would be a better thing than just us clinicians saying, "Oh, these are the things we're going to collect," because then we can put it out there, and it's like, "Oh, well, you didn't do it this way, and you didn't do it that way." I think that's the biggest hesitation why clinicians don't want to really put anything out there. It's because it's probably going to get torn down because we don't know enough, and we don't know what we don't know. So yeah, that collaboration is very important.
Yeah, that's very true. Awesome. Well, thank you for your input on this. It's awesome. And it was great meeting you in person at Pani. And I look forward to seeing you again and continuing to collaborate.
Wonderful to meet you too. And I will take it. I'll let you guys take it from here.
Thanks, Michelle. See you
Thanks,
later.
Michelle.
Everyone. Bye.
Bye.
I feel like, and then there were three.
And I'm giving leave session, and it won't leave the session.
No, you're good. You can leave session, but you just don't hit cancel out the browser. Leave the browser open.
All right. So I am hitting leave session, and it won't let me leave. It's just literally.
We don't want you to leave.
It's grayed out. So I'm gonna just leave this on, and once you shut it down, it'll shut down. I'm just gonna turn off my mic and my camera.
Yeah, it's weird. I'm not. Yeah, what is going on? It's not. I can see. I can't leave. I can't want to leave either if I wanted to.
We don't want you to go, Michelle.
Let me. Obviously, this part can all get cut. We'll cut all this part out. But I know if I stop recording again, then
no. I'm just gonna log off, and then you guys already have my farewell, and yeah, keep going, keep talking.
All right. Bye.
Okay, perfect. Bye.
Bye.
Gotcha.
Great. Okay.
I think something too, like we were saying, maybe if we could paint a picture of what it looks like, what a good collaboration could look like in our community and with colleagues and our medical colleagues and stuff. And I think Tracy is really good at, I think you almost really did paint a good picture earlier when you said you were talking to the ortho group.
Yeah.
And you said you don't have to be just like I don't do MARPE in my office. I don't do MARPE, but I recognize there's a place for MARPE. Does everybody need MARPE? No. But I recognize what kids might have a skeletal crossbite. And then I also ask these other, could we put all the white things together without a MARPE? We could. And yeah, teeth compensate. And I can make straight teeth, or an orthodontist can make straight teeth. Mm-hmm. But if they also have, can we be open to the fact that we really should be asking more questions? What does a skeletal crossbite look like? Do we see compensation of the lower molars? Mm-hmm. Does this child have nasal resistance issues and mouth breathing? Then maybe we have to consider another way to help this kid for their particular obstacle. And then you punt to someone in town that does MARPE and say, hey, I got this kid in the chair. They don't breathe well through their nose. They've already been in the ENT. They've had the things. They've had, and we had Stanley Liu on a while ago. He's like, who's the rhinologist of, another rhinologist beyond the ENT when you've done everything there is to do? Or in a small child when you're not going to address a deviated septum or turbinates. Mm-hmm. It's the dentist, it's the orthodontist. So to recognize that the ENTs even recognize that we have a influence on the nose.
Doesn't that get to how we have to improve our diagnostics though?
Yeah.
Right. Because if we're not diagnosing, like what you just said, and again, I'm not doing this to be disparaging comments about my orthodontic colleagues. I'm just trying to tell it how it is. We're not looking at the majority of what you just
Right.
said. Remember, most orthodontists oppose the concept of taking a cone beam on every patient, even though they make them with less radiation now effective dose than non-3D. Many directors of many orthodontic programs out there refuse to incorporate CBCT into their programs. So a lot of what you just said, Stacy, that's second nature to you and Tracy and myself and Michelle. They're not even, it's not even on their radar. They're not looking at it. So yeah, Tracy,
And
what
you
were
know
you
what?
gonna say?
Maybe you want to be the orthodontist that only sees, 12, 14 and up with your pano, and you're just doing whatever.
I don't know. I still
But
think you need to diagnose at a better level. Like, I
you,
think we
oh
need to
no,
spend
I
more
agree. I
time on
agree.
it.
They do. I agree. I mean, I could not practice without my cone beam. My
And
gosh.
same.
And the fact that it's less radiation. I
Yeah.
just don't understand what the problem is. But like,
Too much
it,
information. No, I've literally been told in orthodontic study groups, literally that it's TMI. They don't want to be responsible for looking at but I
and
think it
this
gets
is
back to,
where,
again, the time, right? When I had to build a system when I put 3D in 2014, there was a total overhaul of my systems. And again,
Mhm.
these orthodontists, a lot of them have multiple practices. So if you've got 4 or 5 offices, you now have to invest 150 grand. Some, I guess, down 125 now. When I bought one, it was 175,000 into all these practices. You've got to upgrade all your server storage. You've got to license all the workstations and all those practices. This is potentially over $1 million of investment they have to do. And we don't get an ROI directly on the billing side of it. Right. So we can't just bill more for, I mean, you could in theory, but you're going to price yourself out. So we used to just bill it as a pan and a ceph, and we made a 2D pan and ceph for everybody. We took a 3D on anyway and saved those JPEGs to the chart.
You know
So
what?
like,
What if we could have, like, I'm throwing this out here. There was a person in my town who did all that imaging for dentists and orthodontists. Like, I
Yeah.
think the problem is this too. In dentistry, we are our own imaging centers. We are our own surgical centers. We are our own. And when you look at medicine, that's not how it works. If you
Right.
need an image, they outsource it.
Right.
Maybe, just maybe we can start having conversations of, hey, orthodontist, if you don't want to make that $1 million investment with all the licensure and the cone beam in your practice, and then what if you could find an imaging, a dentist in town, and you have a relationship where, hey, I'm going to start ortho on you, and you go next door and you get a cone beam. I know that's a pain in the butt, but I mean, that would kind of answer if there's just so much that kind of needs to change within dentistry. It's so expensive to be an orthodontist and to be a dentist, and people do not realize we are our own imaging centers. We are a surgical center. We do everything in-house, and that makes it so expensive to provide the service. And in medicine, that's just not how it works. So to your point, that's valid. You and I took this, you, Tracy, and I, and Michelle, we all have cone beams, so it can be done. And I mean, and I wasn't even an orthodontist, so my ROI was definitely, I just did it because it was the right thing to do.
That's how I felt. Yeah.
It
That's
was the
how I
right
felt.
thing to do.
And
But I also think people don't want to see, and maybe we got to get rid of this. They're afraid to make changes, or they're afraid to not do it because they feel like I want to stay right. I want to, if I can poo-poo what you're doing, if I can make what you're doing wrong, it makes me feel
Yes.
better about, there's that component.
There
There
is.
is that psychological component of, but we need to get rid of that. It's just a lie. Just because you're not doing something doesn't mean you're wrong. It just means you don't want to do it. It doesn't make the other person wrong either. So I just think we have to have more humble dialogue. And like Tracy said, let's not be throwing throwing pies in each other's faces and arrows in each other's backs, and we're not getting anywhere that way. We're not.
Yeah, I mean, I stopped the fight. I think when I first started speaking about it, I was almost like angry that our community wasn't involved, and so I was very adamant about like just posting stuff. And like now I'm to the point where it's like, you know what? There's enough evidence to treat. You're just choosing not to look at it. And there's a lot of, and that's okay. And I think that like you're gonna as long as I continue what I'm doing, what's going to happen is it's going to come to you and you're going to have to do something about it. And that's kind of where it is now. It's like I focus less on trying to convert people and more of just showing things that are positive, showing what's happening. I do think that if you are treating this disease, you have to treat it from a medical standpoint with medical metrics. Like if you're saying that, like, look, like this patient sleeps better, but all you're showing is straight teeth. You're not really showing that the patient's sleeping better. So for example, like in my office, we do testing, we do this, and we work with the other providers. I do think that we have to understand what everybody's role is and the limitations of what they can do. I mean, because people always ask me, how do you talk to an ENT? I was like, well, you talk about their limitations. And they're like, what do you mean? It's like, well, what's in their wheelhouse? What else can't they do? And so when we talk about orthodontic intervention and nasal resistance, well, in a child, their wheelhouse is tonsils and adenoids, turbinate reduction, and they don't really have much after that. And so, but then you have a child with a constricted arch. So then it's on our wheelhouse now. So I think there's less of this co-diagnosis, and it's just, there's so much focus on the treatment. And I think that's where we have to kind of take a step back. Like not everybody needs to be expanded. We talk about that. Like, what's your diagnosis? Right. And so, I mean, and not everybody needs a MARPE. And I even so at the COI Center, which was really what my topic was the discussion of expansion, the evidence, where we are, where we're going, things that we have to be careful about, and like my biggest plot was like, okay, let's look at the evidence. Let's look at what the evidence says and what it doesn't say. And then, like we're beating ourselves. It's like, there's so much evidence in the pediatric I hate saying the Olangarli journal, there's so much evidence in the pediatric ENT journal.
Yes.
Yeah. And like, it's like, I get it. There's not enough evidence in orthodontic because you have different goals. If your goals are, this doesn't improve airway volume, then that's a different goal.
Great point.
We're talking about literature that talks about rhinometry. Like we're talking about orthodontics and the influence on rhinometry. Let's talk about that. That's our goal, is improvement of flow. You're not going to get that in an orthodontic journal because they don't have a lot of evidence that puts rhinometry in there. And if we talk about OSA, well, OSA by definition has to have a PSG and apnea. And well, we know today that like severity of disease is independent of apnea.
Yes.
So,
especially in children.
Yeah. So it's like, I feel like we just have to find a way to have respectful dialogue. And just be like, I understand that this is the limitation of what you do, and this is what I can do. Because, and I even talk about like tonsils and adenoids, and we talk about a partial and a full, and like, like let's reduce the surgical risk. Let's not talk about a full tonsillectomy, which has the number one risk factor is death. Let's talk about combination therapy, and you do a partial and I do expansion. Let's talk about ways to reduce surgical risks as a team for the parents, because like, at the end of the day, like somebody has to tell the parents what you're doing. And then we don't talk enough about like the diagnostics. I mean, like I told you earlier, someone just came to me and goes, I just need a larger airway. I was like, well, what does that mean for you? What do you think that's going to do for you? Right. I mean, like Stacy, you've done everything anatomically at every.
Right. We just had this discussion even with, I had the two doctors, Dr. Gopi and Dr. Lynn from Stanford and Sound Health, and just talking about, volume matters. I mean, Dr. Lynn is the head of sinus surgery at Stanford. And he's like, look, sometimes you do all the anatomical things and there's still the physiology, there's still inflammation, there's still, there's non-anatomical inflammatory components but they're all important. It doesn't mean, see, you shouldn't do anatomy.
Exactly. Yeah.
I mean, you can't say that. It's a piece of the puzzle. So tonsils and adenoids, expansion, myofunctional therapy, diet, gut health. Folks, we all have a seat at the table. Just because one thing isn't the end all be all doesn't mean you don't do it at all. I mean,
I mean, like in one of like I still remember this one of the AADSM lectures, and orthodontist brought up like the whole but Bimax expansion. You know, like it's there are some people that aren't successful. That's okay. I mean, like how successful is tonsils and adenoids, and it's still a standard of care. It's like, and it was like, and if you go in the study, it's like, well, 15 of the 45 got worse. Okay, let's talk about it. Why do we have these outliers? But just because 15 of the 45 doesn't work doesn't mean we shouldn't do Bimax, because that means 30 of the 45 worked. You know, and it's just like,
and let's see why did those work? Why did 30 of the 45? Well, why didn't the 15 work?
The outliers should encourage us to ask more questions.
Yes.
It should not make us feel bad about what we're doing, that we're insignificant. You know, and that's where I think that I mean, if we say that outliers should make us not do it, then we shouldn't be doing tonsils and adenoids. I mean, like,
completely. I'm not even close, right? On the Bhattacharya 2010 study. I mean, it's
what I'm saying.
Yeah.
I remember like one, and I'm not gonna say the name, but like someone was commenting on the chat study. He was like, "Well, do you have a 50% that they grow out of it?" I was like, yeah, but you have a 79% that they do better. It's like, so like you're banking on that. Like, I mean, we just got to focus. There's not enough focus on like the positivity of the study, but it's all, the focus is on like the negative part of that study. And because of the negative part, like, just like you said, Stace, we're just not doing it because like 15 of the 45 got worse. I don't want to be the 15.
And I think a lot of that does come back to the diagnosis or the lack thereof. And because when I coach docs, this happens a lot when they're just like, okay, so if I go in and I develop this arch young and get more space and get more tongue space, they're going to breathe better. Right. And I'm like, it's not that easy. It's not that simple. The etiology is multifactorial. So the solution is often going to have to be multifactorial. You can't, there's no magic wand you can wave. There's no magic bullet where you can target this one specific spot and it's going to solve it all the time, to exactly your point about that, Tracy, right? Like, I mean, if that were the case, and I love that analogy, then what are we taking adenoids out for ever? Because some studies show that greater than 50% do not have long-term resolution. Well, why? And to your point on that, and for what Stacy just said, following up to you, why don't we look at those people? Because what is it? Well, maybe those people have allergic rhinitis and they can't breathe through their noses. So they need to see an allergist because great, their adenoids are gone.
In addition to what you did. In addition to what you did.
And maybe they also do have a narrow arch with insufficient tongue space and a high vaulted palate and poor orofacial muscular tone and et cetera, et cetera. And I think that gets at the very back to where we started this in the diagnostics. That's really hard to do if you're only spending a few minutes with your patient and just looking at the occlusion, right? If you're just looking at the occlusion, which again, to the evidence basis point, I'd still like to see the randomized control trial on class 1 occlusion being superior for, I mean, seriously, like it's convention. I'm not saying you don't shoot for it. My goodness, I try very hard to get any cases I'm involved with and in my practice treated to be class 1. That being said, what high quality randomized control trials demonstrate that class 1 molar occlusion is superior, whether it's functional stability, TMJ health, long-term oral health. Right. I mean, but we do it as a convention. So my point in that is, if we're hyper focused on something like class 1 occlusion, which most orthodontists are, just for better or for worse, it's the way we are, we're not going to see all those other things you just said. And then when someone comes along and tells us, geez, you really need to look at that, that's pretty scary when you think about the fact that it's so involved. And I think that's why so many people run from this, because let's face it, if you're doing well in your practice, you're making money, you're successful, right, financially. I mean, I guess I want to pose that question to both of you, because you speak to a lot of different providers in what you do. What is the motivation for somebody who doesn't have a personal experience with this, who hasn't done the restorative dentistry, as we said before, to see the breakdown, right? If they're just a practicing orthodontist doing their thing, they're making good money, they've got a good practice, they do a good job straightening teeth. The one that Stacy mentioned earlier, that, the 5 letters she got of just going to put a lower holding arch and a Nance, right? How do you motivate? Because I agree with you too, Tracy. And I've backed off a lot trying to change people's minds on this stuff we're never going to change. But I think there are those people out there who, actually I know because I've helped some of them in their journey, who just do it that way because it's what they were taught. And if they did know what we've been talking about, or they could think differently about it, they would change. They want to do better. How do we impact talking about the future? How do we impact more of those people to do things differently?
Stacy, do you want to go
Okay,
first?
I have just a couple of just what I've experienced. For me, the orthodontists that I've been working with in my town that kind of weren't really doing much with it, and now they're really doing a lot. Some of it is, I think a couple of things. One, usually it's personal experience in their own life. They wind up seeing it with their own children or their niece, nephew. Somebody in their family has it, and now they're like, what if? Maybe I should explore this for my own kiddo, which is why a lot of practitioners get into it. And quite frankly, that's why even we had so many people in some of the studies where that Audrey Yoon did with the shrinkage of the lymphoid tissues. There was a lot of medical doctors bringing their kids in saying, hey, let's go ahead and get expansion started. I can't do that. So it's a lot of times it's your own children that you're like, I will step out of the norm for my own child. If it's a chance, it will help. But I also think it's patients asking. And the more and more patients that are asking, they're like, okay, fine. They might be on the cusp and they're like, what? There's got to be more to this. Why are my patients coming to me? But I really do think it's not going to be because they want to make more money or they think, oh, I need to change my practice around and make more money. I'm going to learn pediatric airway. That's never why anybody really gets into that or early.
No, I think actually, sorry to interrupt you for a second, but I think they're afraid they're going to make less. I hate to
Yes.
say it that way, but I've heard people tell me that. So I'm just going to throw it out there.
At first,
right?
you're changing. Anytime you change your practice, you're going to feel this.
Yeah.
You're going to go back and then you're going to go forward because, but
and the consultants are telling them, the orthodontic consultants, a lot of them, they're all about efficiency. They're all about minimizing the time the doctor is in that room.
Yeah.
They want the time to go down because they say you make money in the clinic or doing Invisalign, digital setups. You don't make money talking to the patient and the parent. So the consultant industry, it has made it so about this hyper efficiency. And so I think there's a fear, and if you're now part of a corporate, what about that? How if you're part of an orthodontic corporate? You can't just get a cone beam. You can't just start right. I mean, there's some legitimate obstacles there.
Yeah, who's dealing with he's seeing a bunch of DSOs right now that are wanting to deal with orthodontics and within a DSO. But I guess your question was, what is going to make someone maybe go from not open to do it to open to listening?
Yeah.
I mean, I do think personal experience, family, your own children, that's what I've seen. The orthodontist in my town, I was beating the drum, airway. And they're like, okay, Stacy. And then they had kids and they hit about 3 and 4. And they're like, I wonder. I mean, I can tell you, Jonathan Schenker, he's in my town. He started doing some interesting things with Invisalign on his own children first to stop extraction possibilities. And when he figured it out on his daughter, and he was like, oh my gosh, now he's like, I have a tool in my tool belt that I'm comfortable with to get ahead of this and act early. And it just kind of took something, he was on my podcast, so I'm not saying anything he wouldn't care that I shared, but he and I have been going to lunch for a decade, and it's like, it kind of took something. I think it's comfort, and you see it in your own children, or you don't want to be scolded by colleagues. So I think the temperature,
the peer pressure is real. Yeah.
The peer pressure is real. I think the temperature has to change. I would hope that the AAO would start maybe having more roundtables. Maybe they need to start having more conversations like this where people are like, hey, can we just talk? And maybe I think people are fear fear of looking like they're doing something they shouldn't do, or so if we can remove fear, have more discussions, and people can come to the table. Trace, what is your experience seeing an orthodontist or a pediatric dentist? Like, and I just want to say this, can I just take the heat off the orthodontist for just a second? Where are our pediatric dentists?
Yeah.
Where are our pediatric dentists who have the behavior management nailed?
Well, I
And
mean, but
could
it's
be
the
doing
same
this
thing with
too.
them. It's the same thing with pediatric dentists. I mean, they have a very high volume too.
Yeah.
I
They
mean,
do, but I just kind of want to take the heat off
Efficiency.
the orthodontist
Yeah.
for a
Well,
minute. Like, we
yeah.
need you guys too. But Tracy, like pediatric dentists, orthodontists, two amazing specialties that could be changing so many children's lives. And man, those pediatric dentists, they're seeing kids as little as 1 and 2 years old. You know, like, what converts someone from not doing it to all of a sudden being open to do it?
I
What
mean,
are your stories?
so I can't comment on pediatric dentists and orthodontists. I can just comment on the restorative doctors, you know, like, so, and it's I think nobody wants to change their practice. I mean, like I'm a heavy restorative AACD accredited cosmetic person. So for me, it was more of a, wow, I didn't realize that we had, you know, this much of an impact. And I reached out to the medical community. I think definitely when you first start out, especially if you're a restorative doctor and you have like no orthodontic training and you want to do something, the struggles that I'm hearing from restorative practice is I can't find someone to help. You know, it's not even about kids, even with adults. I can't even find like people that want to do it. What's going to happen is the more we talk about,
Excuse me one sec, Tracy, on that, just so I'm clear, they're recognizing it in their diagnostics, but they
yes,
can't find
but they
like an
can't find
ortho or any.
anything
Oh, okay.
yeah, basically, like, I mean, and I can just speak from the orthodontic, from the restorative side, that they want that GPs are not taught ortho. They're not taught in pediatric management, the same thing.
Yeah.
So like, you know, they're talking about full mouth rehabs, but what's going to happen is the more we talk about the consequences of this disease, that's what's going to drive treatment. The more we understand the consequences of no treatment is when we're going to want to do treatment. And I think what's going to happen is if you don't have the support, you're going to learn it yourself. And that's the bottom line. It's like, if you're not going to be a part of my team, you're not going to be in a team, you know. And then what's going to happen is, like, you're going to bite off the hand that feeds you, you know. So from the specialist side, it's like, if you don't want to alienate your top referrers, because at the end of the day, they're going to find someone to do it for them. And what I am seeing in the restorative world is that they're understanding the consequences. They're understanding the dental consequences. They're understanding the neurocognitive consequences
Of not addressing it.
Of
Yeah,
not addressing
not
it.
addressing it. And they're going to want to find help. From the adult side, it's like they're going to understand the consequences of no treatment to their restorative dentistry. On the pediatric side, and as they have children and grandchildren, they're going to understand the neurocognitive consequences. And the more they understand that, the more they're going to ask for help. And like me, like, if you don't help me, I'm going to find a way to help myself.
Amen. And that's why a lot of, and this is so, Sean Carlson said this one time. He allowed me to come into one of his sessions. And this was, wow, probably a decade ago. And I just really like Sean Carlson. He has a lot of interesting information. He's very scientific with his cone beam.
That sounds great.
He is. He's phenomenal. And he looked at the room. I was the only general dentist in there. And he said, and a general dentist literally, or an orthodontist said this when he was talking about airway and expansion. And the one of the orthodontists are like, oh, general dentists aren't going to want to do this. And Sean looked at the audience and he goes, I'm telling you, not only are they doing this, they've been doing this for decades. And if you don't start doing this, and you know, you're closing off your possibilities as an orthodontist, because more and more dentists are doing the bread and butter class 1 malocclusion, Invisalign. So why don't you become the specialist and open up your mind to what specializing in orthodontics is? It's not just about that. It's not just about the bread and butter Invisalign patients. It's about potentially airway, craniofacial development, helping a child's overall wellness. Like, why don't you become that kind of specialist and really set yourself apart? Really set yourself apart, because the dentists are going to do this. They've been doing this. And like Tracy's point is, it's not that they even want to.
Right.
It's because we have to.
We have to.
Because we can't find anybody to do it. So we're taking the courses and dragging our kids all over the country because we, or now your kids
no one's going to help us.
Because no one's going to help you.
It's funny, like in the restorative world, like I loved it when patients cried, because I always joked around and said like, oh, I'm promoting self-esteem. I'm making people feel better. Like they love their smile. They're smiling more. But when you deal with airway management, when you have someone that says, you saved my life, my child is a different kid. And it's really interesting, because I will tell you, when I first started this, I remember my assistant, who's no longer with me, said, how are we going to make money? That she literally said that in an office meeting. And I was like, you know what? Right now, I really don't care. I just really want to get these kids to the right help. Like just like, if you're not on this bus with me, this is where I'm taking the practice. And but it's crazy, because like my team, when they see a different child walk out of the office, it's so powerful that my team is always just like, I cannot believe no one's looking at that kid. And so it's like, that's my why. You know what I'm saying? Like that's my why. Like right there. I mean, I had a child that, granted, like I don't have everyday miracles. There's some kids that I feel like I was too late, but like the kids that I'm not late for, like I had a mom was like that an orthodontist basically just said, you need to take away screen time. And she was like, I don't think you understand. My child is on the verge of needing a CPAP. This is not about screen time, and then, but the child is a completely different kid. And she was just like, this kid had so many sensory issues, but now hated sports, loves to play sports now, and is like the lead of a play. And it's just, I don't get that with everybody. And I'm not saying that every kid is going to be that way, but when you have that one kid, when you have that one parent that said, you saved me, like it just changes you. And I think that's very powerful. Like when you have that, like something that you're like, wow, this is different. It's a different, like, than what I do in cosmetic dentistry. It's like, it's just, I don't know. It's a different why. Just kind of like when you have that positive stuff.
And I'll come from my adult dental sleep medicine background. So my background's different than Tracy's, and how I even got into it is when you see the train wreck downstream, and that's all you're treating is a bunch of vaulted palate, mouth breathing, inflamed adults with craniofacial issues, and you are putting MADs, or they're having MMA surgery, or they're having CPAP, or like the guy I saw last week, vaulted palate. I mean, it is so vaulted. Oh, it makes me so sad. He just came in for a checkup, and he's mouth breathing in my chair. He's exhausted. His cavity rate's through the roof because he's mouth breathing. And I'm like, we need to address this mouth breathing. And he's like, my mouth, and if people understand, dry mouth is such a quality of life effector. It is a horrible, excruciating feeling. So I'm like, okay, we got to get him to the ENT. Well, the ENT's done all he can do.
Right.
Because
gets back to what we were talking about before, right? The multifactorial nature. Yeah. Yep.
And I explained to the patient, I go, look, I pushed on his palate with my finger. I go, you feel that? And I was rubbing his palate. I said, I'm touching the bottom of your nose. This is the base of your nose. And so you have a TP up in your nose. You really should have a flat based foundation. You got a TP up in your nose. And this is where I said, hey, I'm going to send you over to my orthodontist in town. And look, he's like, he cannot do a mandibular advancement device. He gags too bad. Well, why does he gag so bad? He's mouth breathing. Mouth breathers gag because they're very hyper protective of their mouth, because it's their only form of
their
breathing.
lifeline.
It's their lifeline. So they're hyper reflexive with their gag reflex. So this guy has been turned down from Inspire because he does have mixed apnea. Well, I know that getting him nose breathing isn't 100% going to fix the central stuff, but it's going to help with the obstructive. It's going to help with the mouth breathing. It's going to give him a better quality of life. It's going to get his tongue in the roof of his mouth, hopefully a less dry mouth, Hopefully we can get him breathing through his nose, whose nose has over 40 different functions for breathing. The mouth has 0. Like, let's get him nose breathing. I got to get him to an orthodontist that knows what they're doing. Like this guy, and then he's on tons of gummies because he's so exhausted. This man went from whatever, I'm here for a dental checkup, to I just pulled up a chair and sat next to him. His eyes filled up with tears. And he looked at me, he goes, "Can you help me breathe?" He goes, "I just want to breathe." And he goes, "I can't sleep. I can't." I mean, it's going to make me cry. Like this grown man.
Wow.
So like, what if we could have gotten it? How many people told him no?
Right.
How many people told him no?
Right.
That makes me so mad. Like,
there's that it's not a thing, that there's nothing we can do. Right.
There's nothing we can do, or it doesn't matter. And like, let's get rid of the stupid obstructive sleep apnea. We don't even know what the hell that even is. I mean, I'm sorry. We don't even know
as a label. Exactly.
Like, we don't even know what it is as a label.
Where are the randomized control trials, right? Where are the randomized control trials on pediatric sleep?
The algorithm is messed up, and they wish they never even invented AHI. Yeah. It's only good for, I mean, it's like, we got to get people breathing through their noses, tongue in the roof of their mouth. Can we keep all their teeth that they were created to have? Can we just start having those conversations and like get rid of the OSA thing? Like, hey, if it helps OSA, that's great, but I don't even know what it is. Collapse is a comorbid experience. Collapse of an airway is a comorbid experience to a bigger picture. And we're talking big picture. I don't even want to talk about OSA. I really don't.
The hard part is the reimbursement drives the treatment, right? So often in so many things. And in medicine, sadly, I believe even truer than in dentistry. And that's what they base CPAPs off of. It's all about a diagnosis of OSA, and so that's a big obstacle. There's a lot of,
you said, what can we do? Literally at 3:00, it's 1:30. I'm having a meeting with Miles Moshiri and Shuka Moshiri in town.
Oh, tell him I said hi, please.
I will. Yeah. And what are
Miles
we doing?
Is so great.
He is great. And he's great because I said, hey, I messaged him on Facebook. I got out of the room with that guy that made me cry. And I messaged Miles and I said, can we please talk? Because I want to make sure that what I'm sending you, you understand my why. I understand your why. I understand what tools you have. Could we also add some tools? Let's get on the same page to help this man out. And I want you to make sure, we're all having the same expectations. I'm not sending people. I know we got to go here, but this is it. Like after we hang up here, I'm going to go have a meeting. I'm just going to jump on a Zoom with a cup of coffee with my local orthodontist. Can we just start doing that kind of stuff?
Yeah. And kudos to Miles for being open to it. I mean, it takes both sides of that. And that was Tracy's point, I think, right. Of having just open conversation and dialogue. And just to wrap it up, because I know we do have to step off. I want to just see what each of you think about how I get, I'm sure you do too. Tell me if not. Questions from colleagues and laypersons all the time that they have gone to, or if it's a colleague referred to, numerous providers, and they keep getting told it's not a thing. There's nothing that can be done. We've all probably seen the posts online and in some of these public study groups or Facebook groups where parents will say, I took my child to 4 different providers and they all, my primary dentist is telling me we need to do something for airway, but they don't do it. Then I went to 3 or 4 different orthodontists or 2 pediatric dentists and 2 orthodontists, and they're all saying different things and they won't do it. And then to the next level, maybe they got to a dental provider who understands something about airway and the importance of early growth and development and the diagnostic process that we've been talking about through this episode, but they send to a medical colleague, ENT allergist, who says there's nothing I can do. What are just some words of wisdom you can offer to people out there? Maybe, and for now, let's just focus it just on laypersons, just on the public, because I do think they're going to be a big factor in driving this movement forward as we again talk about the future and where this goes. Look, they did it for Invisalign, right? Orthodontists wanted nothing to do with the clear aligners until patients started coming in and requesting Invisalign, and then the GPs and started doing it, and the orthodontists all of a sudden were all in on the clear aligner market. I mean, that's literally what happened. I mean, I went through school at the time when it was coming out, and we were taught you can never move teeth with plastic. There's no place for it. It'll never work. So, we were against it until the public started requesting it. Obviously, we don't have an Invisalign to run the ad campaign on say Pediatric Airway Health at this point. So what is your advice to those parents who have a child that's struggling? The one that, Tracy, you just said how you turned them around, right, and change that child's life. But that mom or dad have been to a couple people and been told that it's nothing can be done for their kid. What can we do to help empower those people to keep fighting?
So, when we started this podcast, we talked about like where we are today. And I will say today there's so many resources for parents. And, and I tell, and a lot of times when parents come to me, like they're filled with so much guilt, like they talk to so many providers, and I get it. Like if dentists can't get their own kid treated, how does other people, I would say for parents, if we're talking about children, like you trust your gut. Most parents know when the child becomes a difficult child, and you just keep on asking the right questions. And sometimes the person that could answer those questions, unfortunately, may not be in your state. And it's like but the beauty of what we have today is there are a lot of resources. There are podcasts like this one. There's ASAP that really do ask the right questions. And then the next step is finding the provider. I do think that we have to have a better goals. I mean, my ASAPers will tell you that when we do case presentation, the first thing I ask is, what's the diagnosis and what are the goals?
Love it.
Because that has to be very relevant. Like we can't, my goal is never to treat sleep apnea. And I always say that, like, because my goal is to assist your medical team in managing this disease from a craniofacial standpoint. And I'll have parents goes, well, we need to fix the apnea. It's like, no, who else is part of that team? And I think you have to be very honest in that conversation.
Yep.
But like I said, I mean, I think there are many resources, and you just have to keep on asking the questions.
Don't give up. Don't give up.
And like, it's interesting because even like the lady, like I try my best to be a devil's advocate when a patient comes in with saying that this doctor says this, and and I'll tell my ASAPers, like, what's important for us is like we have to be respectful of our peers. Their decision is based on this. And I'll even say that I was like, well, that doctor recommended this because this is what they're seeing, and I understand that. If that is the goal, then that is a very reliable treatment. If the ultimate goal is to do this, that's a very respectable treatment. But if their goal is to do this is what my treatment can do. And then the patient or the parent decides, like, okay, I understand that. Both people are not wrong. Like, and I think it's very important for us not to say someone's wrong, because I think that's where it gets really like, as a parent, you're just like, I don't know who to pick because he says that, like, we're not saying anyone's wrong. We're just saying that we have different goals.
Right.
And I think that's really important for us to kind of like be mindful of it. That's how I see it. Like, but today is so much different now. There's so many public forums you can ask the right questions, and just be respectful in the dialogue with our peers.
I love the goals. I want to underscore that for a second, just because their goal might just be straight teeth.
Yeah. And it's okay. It's okay to have that goal.
That's such a great way to state it. So to clarify it for the confused parent is not because they're like, you all are orthodontists or you all are dentists. How come you don't agree on this? And that's really well said, because our goals aren't all the same. If your goal is just to give them nice straight teeth, and even within orthodontics, not everyone's goal is the same. Some people want a class 1. Some people don't care. Some people want just the front teeth straight. So that's it. It's such a great point. I love that. Get down to when people are confused, say, we don't all share a vision for what our goals are. We don't all share the same goals and a vision for how we're going to achieve those goals. Yeah. And then what were you going to say on that, Stacy?
No, I agreed. I just think it's apples and oranges sometimes. And like Tracy has said that before with, you know, if I'm seeing a 4-year-old child, I'm not trying to get the mandible to, I know I'm not working with mandibular growth at that age, you know, like, because orthodontist, like, why are you trying to bring a jaw forward?
Yeah.
You know, the growth spurt isn't until agreed. But the goal for this 4-year-old is not to help with mandibular growth. It's to have airway patency for this child right now. You know, that's the goal.
Yes.
So, and then that other orthodontist might just go, oh, wait a minute. Okay. My goal, I thought you were out of your mind trying to put a herpes in at night.
Right. I thought you were trying to
You're
fix a
gonna-
class
I
2
thought you were
at
trying to fix this
4.
severe class 2 at 4.
Yes.
No, I'm trying to help a child breathe.
Love it.
Yeah. That's what I'm doing. So
Yeah.
what are our goals? And let's communicate the goals. And you know what? Dr. So-and-so, I'm right now, I have this child in maybe a twin block or a herpst or a myofunctional therapy device to bring the jaw forward at night, similar to what I would do rescue breathing for an adult that can't tolerate a CPAP. But I will gladly refer them to you when I know that growth spurt would be idealized to correct that class 2.
Yep.
So maybe you're not comfortable seeing the 4-year-old for airway patency orthodontist, and maybe that person is. So you two work together, and then you have this beautiful relationship,
And maybe you don't want to be doing a herpst have a bunch of herpsts.
100%. And I'm going to tell you, most general dentists, primary care dentists, like, I just want to clarify, most of us really don't want to do that. We're doing veneers, we're doing implants, we're doing dentures, we're doing partials, we're doing, whatever dentistry.
Yeah.
We have plenty on our plates. Yeah. We are just trying to help children because we are a primary care practice, and we are seeing them from the time the mom was pregnant with them, or that mother was dreaming of being pregnant with them. And we're watching that child walk all through their life. And the orthodontists aren't seeing that. They're not walking this journey, and we are. So please give us some grace as we watch these children in our practices, and we have to do something because no one else will. So we're just asking you to help us. That's what we're asking.
I mean, at the end of the day, like, patients are gonna get someone to help them. So like, they're gonna find someone. I mean, like, so whether it be you or not, and they're gonna find someone. So it's just more like, okay, how can we all do this together? I mean, like, my average new patient commute is like 4 hours, and the people fly, and it's kind of sad that you can't find someone that wants to help them.
Right. Credit to you, but sad on a bigger perspective. Yeah,
it is, like, when you think about it. But
well, I know everybody's got to go. Can I ask my 3 questions? Can I ask my 3 questions before we go? And they're really random. Okay, ready? And we'll try to do rapid fire.
Is it to both of us, or?
It's all of us.
Okay.
What is the weirdest food combination that you secretly enjoy?
Tracy, you want to go ahead?
I like sugar and salt. Like if you give me like salty sweets, I love that.
I think that's good. I don't think that's weird. I think that's great.
Okay, I don't know.
I mean, for me, it's delicious. I love it.
I love it.
Are you part of this, Stacy?
Yeah, I am. I mean, I think about stuff. I like to dip my French fries in mayonnaise more than ketchup.
Oh.
Wow. I didn't expect that reaction.
Yeah, I don't know. I'm just not a mayonnaise guy.
Okay. Ew, you're like, ooh.
So mine would be, let's see, I've got my diet's pretty I don't do dairy. I don't do I would say so ketchup and mustard on a hamburger.
Like combining, you got to do both.
And a turkey burger. Yeah, you got to do both. Yeah.
Ketchup and mustard. My associate told me she dips.
I don't do ketchup.
Cooked carrots and ketchup. And I'm like, that's what got me like, what? How many of us are eating weird?
Ketchup.
Yeah, she dips cooked carrots. And she said, I guess it came from eating pot roast as a kid. Because I always dip my roast in the ketchup.
Yeah.
And I was like, what?
But I've gone to ketchup now, like non-sugar added ketchup, like literally just the tomatoes, vinegar, water, salt. Because if you look, ketchup's got a ton of sugar. So I've gotten pretty strict on the ketchups I'll eat. But yeah, I do enjoy that.
Weird is interesting because like I like everything in fish sauce, but that I don't think that's weird to me. That's because I'm Vietnamese.
Yeah.
That's true, because I would be like,
So like
"Ew."
when you say weird, I'm like, well, I mean, some people might think it's good, but like, I'm Vietnamese. I like everything with fish sauce.
Okay,
Yeah.
here's another one because I know everybody's got to go. What is the well, I mean, I was going to ask, it literally is, what is the worst ice cream flavor you can possibly think of?
So
I
I
can go
haven't
first.
had it,
Good.
but I would say durian.
What is it?
I was like, I haven't had it, but there's like it's an Asian ice cream, which is like durian. So like, because durian smells so I don't even want to
What is
taste it.
durian?
Oh, okay, Stacy, when you come to, I'm gonna have you smell durian.
Yeah, I'm not
What
sure
is
either.
it? What
Yeah.
is it?
It's an Asian fruit.
And it smells funny?
It's not funny. It's
And they
bad.
have ice cream
They have
flavor?
ice cream flavored
That's
durian.
disgusting. Okay, I'll have to smell it.
I would say anything like bubble gum, like that.
Yes,
Like,
I'm with you. I
that,
hate
like,
bubblegum flavored or cotton candy
cotton
flavored ice
candy,
cream.
any
I
of those. It's nauseating to me. I'm sorry.
I do too. I'm like, ooh, why would you want cotton candy flavored? And my kids all love this flavor called Superman. And it was like a cotton candy
Oh,
flavor.
no.
It's disgusting. Disgusting. Okay. I'm sorry. I'm like making all of us sick.
Yeah,
Last
really.
question.
Thanks, Stace.
Last question. Do you have your own Netflix account or do you use somebody else's?
I'll go first and be the outlier. I don't watch a lot of TV. Don't watch
Good
Netflix.
for
I don't. Yeah.
you.
Yeah. My daughter has an account. I guess if we want to watch something on it, we'll use hers. That's almost never. Yeah. I don't tend to
This is kind
watch
of
a
a
lot of shows.
confession.
Yeah.
I
Kind of a
mean,
confession in that.
it's
Yeah.
like
Yeah.
I mean, I have my own account.
I got to stop reading
I have an office account.
ortho and sleep
But
literature.
see, you kind of use your office account.
Yeah, because
So.
we have
Yeah.
TVs on all the ceilings, so like we
Okay.
use it. Yeah, we have
Oh yeah, of
Yeah.
course. Yeah. If you have the office account, there's
Yeah.
no need to have your own. Yeah.
Oh, well, you kind
No,
of
no.
yeah, it's like it's still legit. I mean, you're paying for it, but I mean, I know so many people that are like, "Oh, I use my neighbor's Netflix." I'm like,
Oh, really? Like not even in the house, not
Yeah.
even in
Oh,
the house
no, they
or
use
a
other
related
people's
business.
Yeah.
I might use other people's streaming accounts for other things.
Okay. Okay.
But Netflix, I have my own.
Okay, good
Oh,
deal.
that's funny.
Well, this has been really good. It got really
Thank you.
juicy at the
Yeah.
end, and I'm so glad we had those conversations. And thanks for thinking of this idea, Mike. It was great.
I appreciate you both so much, and to Michelle as well. I know she had to step off, but you guys are just doing awesome stuff, and this is what we have to do. I preface this in my lead in, which you guys didn't get to hear because I was saying I recorded it before, but to say it's going to be a conversation that you're going to get to hear what we all talk about anyway, but like it isn't exactly what we say when we get on stage or when we're presenting, because you have a limited time, you have a topic. Like, this is real. This is what it's about. So I thank you both for and including Michelle, and the honesty and willingness to have these tough conversations, because that's how we're going to change. It's how we're going to grow and move this ball down the field, as I like to say.
We're getting there. We're getting there.
We are.
We really are. Thanks, everybody.
Thanks, everybody.
Thank you, guys. Awesome stuff.
Bye.
Take care.
Bye. This podcast would not be possible without the inspiration of my dad, Daniel Becker, and creative direction and editing from the very talented Jason and Dane Becker, Ben, Lydia, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And please remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice or to replace your healthcare provider's diagnosis or recommendations.